Hello and welcome to the August public webinar on the Digital Quality Measurement Strategic Roadmap. This webinar is held under the Centers for Medicare and Medicaid Services Measures Management System, led by Patel. I am Kate Buchanan, and I support education and outreach efforts on this project. This webinar is part of an annual series we offer to engage the public in the work CMS is doing around quality measurement. Our goal with these webinars is to provide insight on CMS programs and initiatives. Next slide. So before we begin, I do want to cover a few housekeeping items. First, today's session is being recorded. Second, all participants will be muted during the call. You can answer questions in the Q&A feature. We will have an opportunity at the end of the call for a Q&A, but we encourage you to submit questions throughout the presentation. And if you are having difficulty seeing the Q&A window, if you look at the bottom right, there are 3 dots, and if you click on that and hit Q&A, you'll get the Q&A panel. Third, on the right of your screen, you will see a poll pop up. We would greatly appreciate if you took a moment or two to fill it out. And finally, throughout the meeting, we will share resources in the chat window, which is above the Q&A window. So you should see shortly a link for the slides that will be coming in through the chat, and we will post the recording on the CMS YouTube page at a later date. So excellent. Now we can get into the topic. Today, our goal is for you to learn about CMS's Digital Quality Measurement Strategic Roadmap. The roadmap is a multi-pronged strategy to provide better access to usable, timely data to improve quality measurement and patient care. Next slide. Before we jump into the roadmap, I want to provide a little more information on the Measures Management System, or as we call it, MMS. As mentioned, this public webinar is held under the MMS on behalf of CMS. CMS developed the MMS to foster and support standardization, flexibility, and innovation in quality measurement through a series of channels. The diagram to the right shows the many activities of the MMS. If you look at the stakeholder engagement circle in dark blue, you will see our education and outreach efforts, which include this public webinar. I also want to highlight the CMS MMS Hub, which we launched this past spring. The MMS Hub transforms the 100-page MMS Measures Development Blueprint into a comprehensive, user-friendly website. The MMS Hub also highlights upcoming engagement opportunities, including technical expert panels and MMS educational resources. We encourage you to explore this valuable resource at mmshub.cms.gov. I will now turn it over to Joel Andres from CMS to talk about the DQM strategic roadmap. Joel?
Thank you, Kate. Good afternoon, everyone. My name is Joel Andres. I lead the digital quality measure transition work here at CMS. Thank you for joining us to talk today through the strategic roadmap that we've worked on for the digital quality measure transition. Specifically, we'll be focusing on our efforts around data standardization, but we'll also be talking about other elements that are critical to this and how they line up with our move toward data standardization. Next slide, please. This is your mandatory disclaimer, to let you know that what I'm saying is not intended to stand in for statutes, regulations, or other finalized policy at CMS, so do bear that in mind as we're talking. Next slide, please. Thank you. So as most of you are aware, we've been undergoing a fairly gradual transition in how we capture quality measures, beginning with measures that were primarily manually extracted from paper charts. And we've been slowly but surely moving toward a digitized framework for measure collection, both using digital data submission types, with which you're all familiar, and perhaps most importantly for this effort, implementing electronic clinical quality measures beginning something like a decade ago through data captured directly from electronic health records. And what we're trying to accomplish in shifting from the current measurement paradigm into digital quality measurement is to, one, achieve the levels of data sharing and interoperability that we had hoped for out of the eCQM measure implementation, while also bringing in other data sources to allow for a broader set of information to be capturable, shareable, and usable within the context of the data healthcare system. I'm going to be talking through some of the high-level conceptual issues that we've been thinking about and how they relate to our work here. And at a fairly high level, a lot of this has already been presented at other venues, so I'm not going to belabor the points here at the start of the presentation. But if you would like more detail, of course, please feel free, as Kate indicated, to submit questions in the chat, and we'll try to respond to those as fulsomely as possible. Next slide, please. Thank you. So as I think many of you are aware, CMS has committed to shifting to digital quality measurement in its quality programs as a broad initiative here recently. This has required us to begin planning out what the requirements are for that, how our processes and systems need to change, what adjustments we need to make to our measures, but also to our policies that underlie the quality measurement programs in order to support that kind of effort. Next slide, please. Part of that has been thinking about what we actually mean when we say digital quality measures. It has the capacity to be a very high-level buzzword that means many things to many people, and an effort to be more precise about what we're actually talking about. Digital quality, we consider digital quality measures at present to refer to quality measures that operate as self-contained measure specifications, incorporating code packages that apply the measure logic to those specifications. We also consider these to be measures that are able to access standardized digital data that are captured electronically and are able to be computed directly from their computed directly without substantial manual reworking of the data, collapsing the data, and so forth. The goal here is to collect data that can be used directly for digital quality measures while minimizing the burden and level of effort required to make them ready for that purpose. Next slide, please. Thank you. So in thinking about how we're going to accomplish this shift to digital measurement, we developed a roadmap which identifies four primary areas or domains of activity. The one that features most prominently in today's discussion is the one that we think is really the starting point, the kickoff point for this project, which is data standardization. But of course, we also see opportunities to leverage advances in technology through the FHIR standards and API, and the use of APIs for data transmission. And we also recognize that within the context of that, it gives us some opportunities to think about how we can use existing data sets to both aggregate a broader understanding of patient care and to serve multiple needs across the existing healthcare data systems and use cases within both CMS and in the broader healthcare system. And in order to do this, we have to start thinking about how all of these, how these standards can be applied to existing program needs, and then aligning the utilization of those standards, both at the data element and measure level, in order to support the capture of data, the sharing of data, and the use of data across a broad variety of use cases, including quality measurement. So this is really intended to be an approach for us fitting into a much broader project of interoperability within the system. Next slide, please. this we think this fits in very nicely with the National Healthcare Quality Strategy goals that CMS has laid out, including efforts to advance health equity, improving the alignment of seamless and coordinated care through the sharing of clinical and patient data, and also encouraging stakeholders to engage with patients and their families to ensure that the care is reflective of their needs directly. And we think this is an opportunity to accomplish these because it allows us to expand the types of data that we're collecting and the ways in which they can be used while reducing the relative burden associated with collecting those. Next slide, please. And as you can see, there are a number of projects here at CMS that are ongoing, that are considering how we can advance interoperability. Digital quality measurement is certainly one of those, and we see it as interacting with a number of these, including efforts for data standardization through the USCDI and USCDI Plus initiatives at ONC. But we also see it as acting in coordination with these other functions because they create a set of use cases for the data that need to be captured, and and defining the broad set of needs that data requirements should be meeting, rather than simply being limited to the digital quality measurement use case. That is, digital quality data should serve digital quality measurement needs, but those shouldn't be the only needs that those data are serving. I can skip ahead 2 slides here. All right, thank you. So as I said, I think this all starts with data standardization. That's where a lot of our early focus has been, defining how we can standardize data requirements, how we can ensure that the standards we need to support the quality measures we have in programs are in place, but also how we can stand up the infrastructure necessary to advance data collection as our data needs change, and as we try to bring more of the healthcare data system into the fold of interoperability. Next slide, please. So the big picture look at a learning health system. A learning health system is essentially a healthcare data system that allows us to capture data at multiple points, but to use those data throughout the course of the health system to create a greater amount of knowledge about our patients and the care that they receive and the processes that provide those care, and to use that knowledge to improve upon the care that they're receiving, to essentially create a recursive loop of data, information, and knowledge that allows the system to improve upon itself continuously. Quality measurement, we think, it fits within that very importantly because of the need for specified data requirements and the efforts towards standardization that we've undertaken over the last several years. But it's only part of what we need these data for. And so this is a much broader project than just digital quality measurement. And the efforts that we're undertaking in data standardization are intended to reflect that. Next slide, please. So why data standardization? And this is really an argument, I think, that for most people who are familiar with quality measures, this is not an argument that needs to be belabored on. But of course, by increasing the breadth of data standardization and its penetration into the healthcare system in general, you are able to provide for a comparability of data that are collected, which increases your power of analysis. It allows you to break out of the data and use silos that we've created in existing programs and systems where data are captured, frequently data are captured multiple times, but they're not able to flow from point to point within the healthcare system. And that means that any efforts to learn from them are inherently slowed down by the need to match them together in a way that is ad hoc and expensive, and typically, again, is only applicable to certain specific use cases. The goal here is to set up a system that obviates the the need for that kind of extensive effort following the capture of the data. Next slide, please. And right now we know what a lot of those limitations are. Data tend to be captured for needs specific to a given system or program. They fit those needs relatively well, but the data that are captured for that are captured specific to that purpose. And then their utility for other purposes tends to be either limited, non-existent, or has to be kind of shoehorned into that set of needs. And essentially what this means is that we have a limited utility of the data that we're capturing, and we're having to capture data more frequently in order to meet those individual needs that are siloed off from one another. In contrast, by standardizing data requirements, we can ensure that data that are captured for quality measurement, for instance, can be used for other purposes such as quality improvement, can be used for research, for the development of clinical guidelines, the assessment of and the assessment of the provision of clinical care, and back around again. The standardization of data also allows us to develop a common set of tools for assessing the validity and reliability of data that are captured and the mapping of existing data to a particular standard. It also allows us to modify or to reduce the amount of workflow that's created by the need to capture data at multiple points in a repetitive fashion for different programs. And we see that as being an important part of implementing this, because the administrative costs of implementing data collection have been excessive within the American healthcare system, to put it bluntly. And we need to find a better way for capturing the increasing amount of data that we think we depend upon for the provision of good healthcare, without exacerbating the administrative burden that exists independent of the care provided to patients in order to meet those data needs. And that, again, is really the focus of this project. Next slide, please. So we've talked about standardization. The question then turns to why we're focusing on the FHIR standard. Again, a lot of you may be aware of this already, but the FHIR standard gives us an opportunity to align the eCQM reporting requirements with existing clinical data exchange frameworks. The data that are exposed in consistent formats for eCQMs can also be used for other purposes, which means that the administrative burden for eCQM collection is not necessarily added on top of or novel to our quality programs, but can be used for a variety of purposes. It also gives us the ability to provide near real-time feedback on quality measurement for providers. And as a side effect, also allows us to democratize the processing of this information through the development of supporting tools that can apply quality measure logic outside of the large internal CMS systems that currently undertake that project, and then provide feedback and reports that may be annual or quarterly if we're fortunate. And then finally, it promotes the context of interoperability because it provides you with data that can be turned to a variety of purposes. The QDM data model is fine for quality measurement. It is not necessarily applicable to all of those other needs. And that means that its value for promoting interoperability outside of quality measurement is fundamentally limited, and FHIR gives us an opportunity to break out of some of those limitations. Next slide, please. And conceptually, we see this as being accomplished by taking existing data systems, mapping them within the EHR to a set of predefined API endpoints or data elements that can then be exposed to queries from APIs, including those that support CMS quality reporting. And then that allows EHRs to support the quality reporting programs. But once those API endpoints are exposed, if they've been standardized, and other kinds of programs from private and public payers, the state and federal level, from internal quality improvement efforts and other third parties who make use of the data. If they have aligned their business needs with the data standardization we're talking about, they can also access those data without requiring a novel set of effort or requirements on the part of the EHR. Those data are accessible and usable across those use cases and not limited simply to meeting CMS quality reporting requirements. Next slide, please. So that's the case for why we think data standardization is going to be important for what we're doing. I'll turn now to a discussion of some of the activities that CMS has been undertaking in order to accomplish this. Next slide, please. Thank you. So in view of the FHIR standard developments, we've been taking the first steps of authoring our existing eCQMs in the FHIR standard to allow us to see what those measures would look like, to develop our own expertise in them, to identify gaps in FHIR standards so that we can pursue additional standards development through HL7, and also to allow us to seek to identify where we can set in place data standardization requirements and resources that are relevant to our programs, but not necessarily limited to them. A key area of this has been through the USCDI, which is a core data set that is developed by ONC in response to statutory requirements in the CARES Act that allows the identification of a core set of data elements applicable that certified IT vendors are required to support. It also allows us, we've also been looking at engaging with ONC on the USCDI Plus initiative, which does much the same thing, but without the same direct regulatory impact, and targeted toward more specifically toward use cases such as quality measurement and public health. Next slide, please. So in contemplating the authoring of eCQMs, so I said our goal ultimately is for digital quality, is to achieve digital quality measurement across our programs. And that doesn't mean we expect that we'll be limited just to eCQMs as they currently exist, or making all measures eCQMs. We're starting with eCQMs as our initial model and use case for this, because they already make use of data standards, which is something that is not necessarily true of all quality measures collected through other data sources. So we see this as a place to begin the process of bottling out what we would need. And so internally, CMS has been working with its measure developers and contractors to plan out the conversion of measures, of QDM-based measures to the FHIR standard, while also developing tools analogous to the Matt and Bonnie tools we've used for eCQMs in the past to allow us to both author specifications consistent with standards and then to validate those measures. And so that we expect that model of development for eCQMs will allow us to pull in quality measures from other data sources, including potentially Medicare claims, the NHSN, CAPS, and others that are too numerous really to describe, but are all intended currently for capturing quality measures in a variety of programs, which kind of illustrates the point of the fragmentation of data collection that currently exists. We have all of these requirements in place to collect data, but they're unique to specific settings and specific program needs. And the standardization here we see as an opportunity to limit the extent to which we are repetitively collecting these data. Next slide, please. So as I said, one of the key areas we've been engaging in is ONC's USCDI process. So you may be aware, ONC recently published version 3 of the USCDI, which incorporates new data classes and data elements as part of the requirements for certified health IT. Simply publishing the new version doesn't, of course, accomplish that. There are regulatory steps that have to be taken. But in the interim, this helps us to define new standards for data classes that we see as being part of the core, to health IT infrastructure and vital for capturing health and personal information of patients and to support interoperability for a variety of use cases. So the data classes that we've been identifying for this purpose have related to information describing medical or patient encounters, medication and laboratory data, vital signs, health insurance information, and observations or even facility level identifiers. In our mind, this is because it's important not only for key clinical concepts to be captured, but also to ensure that the contextual data about when patients are seen, who they're being treated by, who they're being seen by, when they're being seen, that all of this information is vital to making use of the clinical information as it transfers from one location to another, that the data users within the healthcare system are able to then make use of the data, even if they're not the original system that had collected it. And it also means that we would expect these data to be useful for purposes outside of just what it was originally captured for, which is vital to any kind of concept of interoperability. Next slide, please. So in addition to this, we've been engaging with ONC, and are fairly early into this process, for a USCDI Plus quality measurement domain. The purpose for this is to identify data elements that may not necessarily fit within the core USCDI, but still are relevant for quality measurement initiatives at CMS and other programs, and potentially other programs as well. And it would allow us to capture data or standards for collecting specific data elements that are relevant to these quality measures. And the goal here is to essentially have a repository where identified data element standards can then be used can then be applied to quality measures or other related use cases without recreating the standards or creating competing standards that then undercut the utility of the interoperability project. And so it essentially creates a location for us to identify data that are relevant for quality measurement and then agree upon in a systematic way how those data can be captured across the healthcare system. Next slide, please. Thank you. And part of this is recognizing, of course, that quality measurement is not limited just to CMS, or even indeed just to the CMS quality programs. And there's a need to engage in an alignment of those data elements to understand what data elements are required, what data elements are needed to meet current measurement needs, and to provide a mechanism by which future data needs can also be incorporated into this process of standardization. One of the interesting things that comes out of this harmonizing process is we've always been so focused on harmonizing on the concept of harmonizing measure specifications. But this does, I think, miss some of the point of what we're trying to accomplish here. Rather, by harmonizing on the data elements that we're collecting so that the data elements are useful across a variety of needs, that means you can actually, yes, calculate analogous measure results in different systems so that they're comparable, but you can also potentially reconfigure those data elements to meet program or business-specific needs without compromising the ability to also produce aligned data. And that means that the data are more flexible. They can meet needs that are more specific to a given business or location. or purpose, and yet without that flexibility, then also adding additional data collection burdens to these sources of those data, the HRs, and ultimately the patients and clinicians whose work and treatment produce the majority of these data. In addition to working with ONC on this, we've been talking with other federal agencies, perhaps most specifically, including the CDC, who are undertaking a similar effort in the area of public health to try to identify what data elements are relevant. We expect that there will be overlap in these data elements, and where that's the case, this gives us an avenue by which we can ensure that data elements that are useful for both public health and for quality measurement are likewise standardized across those two domains as well. And if they're utilized in other use cases, we'd expect to see that same kind of standardization across them, so that the data elements, as they're defined within USCDI Plus, are still usable. And it should go without saying, but I think we've gotten this question before, that elements that show up in USCDI Plus would also have to be standardized with what shows up in USCDI to ensure that there's not a conflict in the definitions that are applied there. And we've been talking with ONC about this a lot, and I think they've been very responsive to that as a fundamental and underlying need of this project. Next slide, please. Another area where we've been engaging is with HL7. We've been trying to push for new standards where they aren't currently available. Social determinants of health are a good example of this, where efforts like the Gravity Project have been pursuing new data elements to capture information about patients that help us provide context about the care they need, the care they receive, and their access to resources and other information that can affect the patient care process, but can also potentially be supported by the provision of better care and accountability within the healthcare system. Next slide, please. Right. I think the other piece of this, of course, is that it's not simply a matter of us setting forward efforts at data standardization, putting out a list of data elements, or even revising the requirements for our programs. This is something that we see as a very interactive kind of project, in that we're going to need support from the broader vendor and provider community in implementing data standardization within the systems. Some of this we can affect through setting data requirements for our programs, but of course it also involves a commitment to supporting interoperability more broadly. And some of the ways we've been pursuing doing this is through the publication of requests for information through our rules. Most recently, we've provided requests for information about a number of issues related to pushing for digital quality measurement. These include getting feedback on potential revisions for definitions of digital quality measures to ensure we're capturing all of the elements that will be necessary to render a quality measurement truly digital and interoperable. We've also been engaging with external as well as internal federal stakeholders on data standardization activities. We've been encouraging people to participate not only in the HL7 process for advancing standards, but also we've been seeking feedback on specific implementation guides and reminding people that they have the opportunity to participate in ONC's USCDI efforts to identify what core data elements are relevant for interoperability and pushing that forward. And then finally, we've been outlining within the RFI activities that CMS is anticipating undertaking in preparation for FHIR eCQM reporting, which includes providing opportunities to give public comment on measure specifications, reviewing flows for improvement of data opportunities and getting feedback from vendors and providers about these, about the processes that they anticipate and the barriers that they anticipate as we seek to implement FHIR-based reporting. Next slide, please. So in thinking about how this is laid out, we have, as I said, general feedback that was related to the transition for digital quality measurement. We've started to receive some of that feedback. Broadly speaking, we've seen a fair amount of support for efforts to shift to digital quality measurement, as well as some hesitation around the potential timeline and the desire to ensure that CMS is being mindful of the efforts that will need to be undertaken in order to implement the FHIR standard and reporting based on APIs. And so there's certainly been a request to ensure that we are allowing for enough time for that to be implemented. And there's been a push for us to recognize that the transition itself is of course not a trivial one and will involve the application of a fair amount of resources. In thinking about refining the definition for DQM, we've certainly got a lot of interest in hammering out exactly what a DQM is. I think some of the areas we need to improve on this is providing better examples of DQMs. Right now, we can show eCQMs fairly straightforwardly, but of course, we don't really have at this point non-eCQM digital quality measures that we want to that we can show publicly and say this is how this works. Part of what we see as the next stage of advancing the implementation of FHIR is moving beyond eCQMs to some of these other data sources, and I think that's something will be that expanded conversation will involve providing some examples of how we see that working. And so I think that sort of identifying where that switches from eCQM into DQM is going to be an important part of CMS defining it in the future. Right now, the majority of our efforts, however, are focused on eCQM specifically, and so that's where most of the conversation about implementation are going to see is. And then, of course, there's been a lot of concern about the lack of standardization outside of EHR data sources, and that's something that we see as a critical part of bringing other data sources into the digital quality measurement fold. Because again, that stage of standardizing data capture is going to be necessary for all the other elements of digital measurement to be adopted. Next slide, please. Thank you. In terms of the feedback we got for our data standardization activities, there was a lot of support for CMS allowing for input on the implementation guides that we're considering for digital quality measures, which is only to be expected. There's always interest in transparency and what CMS's plans are and opportunities to comment on them. There's also a lot of support for alignment between the USCDI and the future USCDI plus quality measurement base, which we also agree is critical for this. We received recommendations to continue testing and validating implementation guides and allowing for additional opportunities for stakeholder input and to ensure the maturity of implementation guides and alignment across those guides. I think one of the areas that we see as a primary of concern for this is the proliferation of implementation guides across many programs, not just ours specifically. And so we're contemplating strategies we might take to simplify the intake of implementation guides, or even streamlining the development of implementation guides so that they represent less of a burden for intake for providers and vendors. Of course, the risk here, I think, is that if there are too many implementation guides and they don't align well, then you end up with the same kind of problem you had with a lack of fidelity to a common standard, which it's just you've moved the problem on to the implementation guides that define how the standards are applied within the system, instead of the issue being a lack of a common standard. And that would I think be a tragic thing if we simply left that unaddressed. Regarding the approaches for achieving FHIR reporting, we've received recommendations to continue participating in connectathons to give opportunities to participate in implementation of API collection and eCQM reporting using the standards. We've also received suggestions that CMS conduct a large-scale testing of FHIR-based reporting and consulting with multi-stakeholder groups prior to adopting the use of FHIR-based reporting widely. And then with regard to data flow options, we've received support for clinical quality language, the use of FHIR standard and APIs. There are concerns that we've been hearing about data security and privacy considerations, such as who can see what data, when, and for what purposes. We agree that's something that needs to be fleshed out in a more complete manner before this can be implemented. Because ultimately, what we want to see are data that are transferable in a way that protects patient privacy. But for those organizations that have a legitimate need to make use of those data, coordinating care, ensuring the best care is being provided to their patients, we want those data to be reasonably accessible and exchangeable within the overarching system. We've also received suggestions to explore additional API functionality requirements and the costs associated with those in order to ensure that as we're setting forth those requirements of the programs, we're not inadvertently creating additional areas for burden in implementation that may prove to be problematic, especially for smaller or less well-resourced providers. And then finally, I think for data flows, there's a real interest in establishing a real-time data exchange and rapid feedback loops. And we think that API-based data exchange gives us an opportunity to pursue this. Obviously, policies need to be adapted to address that as well, so it's not a foregone conclusion. But this is something that CMS has been wanting to pursue with greater alacrity, and it's an area that we think we have the opportunity to do so. Next slide, please. We have also, earlier this year, published a digital quality measures page on the eCQI Resource Center. The URL is provided here. It provides some baseline information about the approach, about the roadmap itself. It also provides more detail about some of the non-data standardization arenas that we're considering for implementation, and provides links to other resources and tools. We expect to be updating this as we proceed down the path of the roadmap in the coming months and years. Next slide, please. Right, so looking ahead, next slide. So all of this comes back to the concept of a learning health system and building into it. So as we're building out these requirements, as we're building out these processes, we want them to be things that can play well in an environment where interoperability is being pursued elsewhere. And so that's been a key part of the concept of aligning with other federal organizations, but ultimately we'll also need to be a part of the conversation with private organizations as well. Next slide, please. And that need for alignment is going to require an ongoing condition. It's not one that we think can be finished with the implementation, prior to the implementation. It will have to be continuing and ongoing as data needs change, as the tools we have to make use of those data also change. We expect there's going to need to be the infrastructure in place to be able to manage for continued alignment, continued implementation of new data requirements, and also to ensure that that a broad base of data needs are represented within these standards and requirements that support and underlie the learning health system. And that means that there has to be, broad-based engagement, not only among federal organizations, but also among private, state, and other stakeholders. Next slide, please. And so with that in mind, we've been talking about to identify those different parties that we think are going to be relevant. Some are we have more ready access to because they're already involved in digital quality measurement. Of course, many others may make use of the data, but do so for other purposes that aren't directly related to our programs. And for that reason, we're reaching out to the parts of CMS and ONC who have a broader-based experience talking with these organizations to get them also involved within the conversation. As that is getting underway, next slide, please. We can also think about how it's possible for stakeholders currently to stay engaged with this. This includes becoming familiar with the DQM webpage on the eCQMs Resource Center that we've provided a link to above in the chat. It also involves taking advantage of some of the opportunities that will be coming your way to provide feedback on the quality measure specifications that we're pursuing, as well as the implementation efforts for our programs. This includes RFIs and any future rulemaking proposals that we would need to carry out in order to facilitate implementation in our programs. Of course, as with any quality program initiatives, we need to incorporate those, or we need to undertake that rulemaking in order to get it in place. And then finally, I should say finally, but participating in the USCDI processes, providing feedback on the data element priorities and needs, engaging with HL7 to identify or to advance data standards that are necessary for data needs, whether they're unique to you or more broadly based, and looking out for opportunities to collaborate via systems testing for the FHIR-based eCQM reporting, the Connect-a-thons that are being hosted by with HL7 and by CMS in order to support implementation down the road. Next slide. So this is my email, and again, the link to the DQM webpage. If you have any questions beyond what have been asked in the chat or that we can get to today, please feel free to reach out, and we'll be happy to talk with you and discuss what either solutions or to get your feedback on issues that you may see with what we presented here today. And with that, I'll open it up to questions and the Q&A.